Well, hello there. This is Mrs. White, and this lecture is on dementia and will include Alzheimer's as well as delirium. All right, so dementia is one of the disorders of cognitive impairment. And basically, cognitive impairment is any deficit in intellectual functioning. This can include memory, orientation, attention, and concentration problems. It can have a devastating effect on not only the patient but their caregiver. Dementia adversely affects the functional ability to work, to fulfill responsibilities, and to perform their ADLs. It puts the patient at high risk for injury, impaired cognition, and social isolation. And there is usually a concurrent problem with depression, because patients with dementia and delirium may also have symptoms of depression. And dementia and depression are often mistaken for one another, especially with the older adult. If a person has depression with dementia, they may have manifestations such as sadness, difficulty concentrating, fatigue, apathy, feelings of despair and inactivity. Severe depression will lead to poor concentration and attention, which will then lead to impaired function and memory. If a dementia has depression and they occur together, that could indicate intellectual deterioration. So the most common causes of dementia are the irreversible neurodegenerative disorders. So things like Alzheimer's, Lewy body dementia, frontotemporal dementia, Down syndrome, Parkinson's, Huntington's, ALS, vascular dementia. There are several modifiable and non-modifiable conditions that could lead to the development of dementia. So again, some of those causes might be the neurodegenerative disorders, which by far and away is the most common. It could be vascular disease, immune disease, systemic diseases, trauma, tumors, ventricular disorders, substance abuse disorder, use of drugs, alcohol. There are, again, many different ways we get there because dementia itself is not a disease, it's a collection of symptoms. Clinical manifestations of dementia really depend on the cause, but it is a gradual onset with progression. When we're doing a patient history and we're trying to figure out what sort of manifestations does this person have that could or could not be related to dementia, we want to look at problems with judgment, reduced interest in their hobbies, repeating their questions, their stories, or their statements, trouble learning how to use tools and appliances, forgetting the correct month and year, difficulty handling their finances, difficulty remembering appointments. They may have consistent memory issues with taking their medications. And as far as our workup, we'd also want to look at what medications is a patient on. Especially as we get older, our patients are more likely to experience side effects of medications, and they also tend to take more of them. So you want to be able to do a good medication history, looking at not just prescribed but over-the-counter medications, herbal supplements, any recreational substances, and some other medication classes that are known to cause cognitive impairment, things like analgesics, anticholinergics, psychotropic medications, and any of the sedative hypnotics. When we're working up dementia and delirium, the patterns of the onset of the dementia symptoms can help sort of define the cause, whether something is an underlying metabolic issue or maybe an infectious issue. All right, so diagnostic studies. Basically, we want to rule out factors that we can help control. So we might need to rule out hypertension as a cause. Some of the other issues that a person can have that would lead to dementia would be diabetes, smoking, cardiac dysrhythmias. So again, we're looking to see what we can do as far as ruling out other disorders, ruling out some reversible causes of dementia. And you can see here, this is imaging. We especially like to do imaging if we have a rapid onset dementia. And you can see the picture A is a person who had a mini mental status exam 21 out of 30, and they have white matter changes. And the patient B, who also has an altered mini mental status, and looks like they've had strokes, lacunar strokes. And then the control patient is in C, that's the normal brain of a 77-year-old. Okay, so now we're going to go specifically into Alzheimer's disease. We'll start with some fast facts about Alzheimer's. So you can read up there about as far as what some of the risk factors are and some of the facts about it. So approximately 11% of people age 65 or older have dementia. A third of the people over 85. Early onset dementia is when the signs and symptoms occur when they're 65 or under. And late onset is when they're greater than 65. It is a chronic, progressive, deadly disease. Death typically occurs 4 to 8 years after diagnosing it. It's the sixth leading cause of death in the United States. It can't be prevented. It can't be cured. We really can't slow the progression either. 25% of people caring for someone with Alzheimer's disease are also caring for a child or a grandchild. It's often been described as a very emotionally stressful activity. Folks often have to stop working to provide care. And they also tend to, as far as caregivers, deny their own health care needs to take care of their loved one. Men have a higher incidence of vascular dementia, though women have a higher risk of dementia overall, because 2/3 of people who are diagnosed with Alzheimer's disease are women. And we're more likely to develop it because we tend to live longer. There are some cultural and ethnic health disparities that older African Americans are 2 times more likely, and older Hispanics are 1.5 times more likely to have Alzheimer's disease compared to the Caucasians. And this would be due to differences in health, lifestyle, socioeconomic status. There's also an increased risk of Alzheimer's disease when you have lower education levels. The exact etiology is unknown, but we'll talk about it. So, risk factors. There is a lot to be said about vessel health in general and the vessels that feed the brain. So diabetes significantly increases the risk of developing Alzheimer's or any other dementia. And that's because of the chronically high levels of insulin, and glucose may actually be toxic to the brain. Insulin resistance may interfere with the inability to break down amyloid, and high glucose and high cholesterol lead to vascular dementia. Head trauma is also a risk factor for dementia. Traumatic brain injury and PTSD patients, they have a higher risk of Alzheimer's disease or other dementia. And this would include things, people like football players and our military veterans. As far as pathophysiology, Alzheimer's is thought to develop due to plaques and tangles. Basically, plaques are clusters of insoluble deposits of beta amyloid, other proteins, remnants of neurons, and non-nerve cells like microglia, other cells like astrocytes. In Alzheimer's dementia, these plaques develop first in areas of the brain for memory and cognitive function, and then they progress to the cerebral cortex areas for language and reasoning. And this leads to neurofibrillatory tangles, right? Those are abnormal collections of twisted protein threads inside the nerve cells. The main component is something called tau. That's an important protein that supports intracellular structure. So in Alzheimer's disease, these tau proteins are altered. And what we know is that these plaques and tangles are more abundant in people with Alzheimer's dementia when we look at them upon autopsy. We also have brain shrinkage. And so these pictures that you see here show the plaques and the tangles and the different sizes of the brain. You have here a list of early warning signs of Alzheimer's disease. I want to bring to your attention a phrase that's called retrogenesis, and that's why I have a picture of Benjamin Button. That's the movie where the man started out old and then did reverse chronological aging. So retrogenesis is a process whereby degenerative changes mirror in reverse order brain development from birth. So developmental stages in children are compared with the deterioration of Alzheimer's disease patients. Symptoms don't always correlate with abnormal changes in the brain, and we can categorize dementia into different stages. For Alzheimer's, different stages. These stages are mild, moderate, and severe. There is progression from mild to severe. It's highly variable from person to person. It can range from 3 to 20 years if you look back to when the person had symptoms. The initial symptoms that we see are usually related to changes in cognitive function, and family members often report that to the healthcare provider. The difference between dementia and non-dementia issues is that normal age-related memory decline doesn't interfere with ADLs. So for us, dementia and Alzheimer's, it does. So normal age-related changes would be recent memory loss, but dementia would be recent memory loss, remote memory loss, and then interference with ADLs. There are additional cognitive impairments with progression, things that can lead to dysphagia, apraxia, visual agnosia, dysgraphia, and eventually long-term memory loss and the inability to recognize family and friends. So as you can see, this can be very stressful. So you can see here, this specifically speaks to retrogenesis. Remember, it's based on functional assessment staging. And you could see it basically broken down to developmental age. So as we have severe dementia, the person will eventually behave as a 1 to 3 month old, unable to hold up head. They lose ability to smile as they go along. So this is a very devastating thing to watch for the family members, the caregivers. There is something called mild cognitive impairment in that early stage. Basically, the person would have problems with memory, language, and other functions very noticeable to the family, but may not be noticeable to others or seem normal. But it would show up on screening tests. So remember, if a person is able to perform their ADLs, that does not meet the criteria for dementia. And this is what I was talking about, mild cognitive impairment. This is the second stage. Again, the person may look okay from the outside looking in, but the family members will give you a different perspective on that. So you often need to talk to them. So primary treatment of mild cognitive impairment really is based on careful monitoring. We want to be able to note declining memory and thinking skills, the early warning signs of Alzheimer's, dementia. 15% of people who have mild cognitive impairment go on to develop Alzheimer's, and there is no drug therapy currently available for mild cognitive impairment. All right, so just moving up here to the diagnostic studies. Remember, Alzheimer's dementia is a diagnosis of exclusion. It's made once all other possible conditions causing cognitive impairment have been ruled out. We do need a comprehensive patient evaluation, their complete health history, a physical exam, neurological and mental status assessments, depression screening. Lab tests would include glucose, creatinine, BUN, vitamins, looking at their thyroid and liver function tests, ECG, so checking out the heart. Brain imaging tests would include a CT or an MRI, which might show brain atrophy. PET scan can distinguish Alzheimer's dementia from other dementias, which it can detect the amyloid plaque. But remember, definitive diagnosis really does require brain tissue examination at autopsy. There are some different things that we are looking at, which are some of the biomarkers. Again, they're promising. Biomarkers are promising, but more research is needed. So they're looking at the levels of beta amyloid accumulation in the brain and injured or degenerating nerve cells. So it's just something to be aware of. As far as testing, there are several tools that we have at our disposal to look at a person's functioning. Among them are the mini-cog, which is a clock drawing test, the mini mental state exam, which is something that I've done frequently. You'll see this often done in long-term care. And then we have the Montreal Cognitive Assessment, which is a little more in depth. So to give you something to look at, right here is a clock drawing test. Somebody with early Alzheimer's disease, you could see the clock they drew. And then moderate Alzheimer's, their clock, and then severe Alzheimer's. So again, a clock drawing test, it's a simple test, can be used as an assessment technique. We basically just ask them to draw a clock, put in all the numbers in the hands, and we tell them to set it at 11:10. Interprofessional care of the patient with Alzheimer's is aimed at controlling undesirable behavioral manifestations and providing support to the family caregiver. Medications do not cure or reverse progression of the disease. There's been some modest decreases in the rate of decline, but really no overall effect on disease progression. But we tend to put patients on med after med just because we want to be able to say we're doing something. Some of the medications that we do use are listed here. If we're dealing with decreased memory and cognition, we use the cholinesterase inhibitors. These are things like donepezil, rivastigmine, galantamine, so Aricept and Exelon. We use N-methyl D-aspartate, which kind of blocks glutamate, so that would be Namenda. Depression, we like to use SSRIs, including fluoxetine, sertraline, citalopram. Those are the most common. And for sleep disturbances, if it's because of depression, trazodone would be indicated, and sometimes zolpidem. But understand that a lot of the medications that would induce sleepiness can also be very dangerous for our patients who are already risk for injury. We might use antipsychotic drugs. There has to be clear indication because these are often considered chemical restraints in the elderly. They have to be dangerous to themselves or others, and it has to be significant. And if we do use these medications, we might use Haldol, which can cause a risk of death in the elderly. Risperdal is commonly used. You may see Zyprexa, Seroquel, and Abilify as well. So the goals for the patient are to maintain functional ability as long as possible, live safely, and not experience injuries, be able to complete their ADLs and address their needs that they cannot do, maintaining their dignity. We want them to avoid harmful substances, challenge their mind, exercise regularly, avoid trauma to the brain to help keep the brain healthy. And then also we have another patient here, which is the caregiver. So we have to look at the caregiver stress, their functioning, their ability to meet the demands that are placed on them as being caregivers. All right, as far as acute care of somebody with dementia, for somebody who's in the hospital and they have a diagnosis of Alzheimer's dementia or other dementia, you need to look at their safety as a priority and understand that they may have a worsening of their dementia as they are in an unfamiliar environment, and also as they are ill, they are less able to compensate. Requires frequent observation. These are the patients that often go on one-to-one. They might need frequent reorientation and reassurance. And we need to often anticipate their needs and respond to them, which makes them sometimes harder patients to take care of, but it's very necessary. Consistent nursing staff can help decrease anxiety and also decrease disruptive behaviors. So that's if they're in the hospital. All right, so treatment of dementia in the early stage. It's important to know that demands on the caregiver can exceed their resources. So memory aids can be used in early stages. The person may need adult day care, and those are common. It was very difficult during the COVID-19 pandemic when all of the daycares closed down, and that put additional caregiver strain on the caregiver. They may need long-term care placements. There are special dementia units common. They have an emphasis on safety there, and it's a secure environment that allows the patient to walk freely but not wander outside. Late stage, these patients are dependent on others for their care. You may see them develop more behavioral problems, problems with nutrition, elimination. They become more and more incontinent and unable to maintain their ability for self-care. As far as behavioral problems, 90% of patients have behavioral disturbances. These could be things like asking the same questions over and over again, delusions, hallucinations, being agitated, aggressive, can lead to altered sleep patterns and wandering, hoarding, resisting care. These behaviors can be unpredictable and challenging. They're unintentional behaviors and they're very difficult to control. And this is what often leads to the placement of patients into the institutional care setting. But often behavioral problems are a patient's way of responding to something that they can't tell you otherwise. Pain, frustration, temperature extremes, anxiety, the need to use the bathroom, that they're hungry. There's a lot of different reasons why someone might have behavioral problems. The one thing I know for sure is that patients with behavioral disturbances are more likely to be abused. All right, so here's just a little graphic on different things that patients may be doing related to why. So you need to assess the patient's physical status, their vital signs, elimination, and pain. Look at their environment, including temperature or noise. You might need to move the patient or remove the stimulation. You need to reassure the patient about safety. Especially in the hospital, you might need to remove tubes and dressings from where they can see. You need to rely on their emotional state rather than verbal communications because they're not logically acting. Use validation, but don't ask them why. Some of the strategies we have for difficult behavior are redirection, distraction. Remember not to threaten or restrain your patient. It may be necessary to have a family member there, even if it's outside of visiting hours. You want to use positive nursing actions and avoid using medications and restraints. Remember to always look at pain as a possible factor and recognize and treat it promptly, and then monitor the response to pain. They may have difficulty communicating their complaints, so we might use a different pain scale. Like there's one that's called PAIN-AD, which is pain in Alzheimer's dementia. Another challenging behavior that exists is called sundowning, right? This is a specific type of agitation. It's not really clear, but the patient becomes more confused and agitated late afternoon and in the evening. It could be due to disruption of the circadian rhythms. Other problems could be pain, hunger, noise, being in an unfamiliar environment, the decreased lighting, interrupted sleep. So, in order to take care of a patient who's sundowning, remain calm, avoid confronting the patient, create a calm environment. You want to maximize exposure to daylight. Many times I come into the hospital and my elderly patients are sitting in the dark with the shades drawn during the day. That can lead to disruptions in their circadian rhythm. So I make sure when I go into those rooms that the lights are on and the shades are up, that they get natural light throughout the day. You might want to evaluate the meds the patient's on, limit their naps and caffeine, and then if they become extremely problematic, we may need to discuss this with the healthcare provider. Safety is a huge concern, not just in the hospital, but especially at home. So we want to minimize risks in the home environment, and we can do this by assisting the caregiver to assess the home environment, looking at those safety risks, and implementing safety strategies. Supervision is often needed because wandering is a major concern. It's related to memory loss, the side effects of meds, curiosity, perhaps memories that are triggered from earlier routines. So you might need to observe them for precipitating factors or events. I one time had a patient who was a baker, and every day he would get up in the middle of the night, he would start trying to get out and leave. And you couldn't reason with them, not at all, because again, they're not logical. So you often have to meet a dementia patient where they're at. So I found out that he never worked on Sundays. So every day I worked was Sunday. Every time he would get out of bed and he would be like, oh, I've got to go. Because when he was a baker, he had to get up at 3 a.m. and go to work. So I'd always remind him that it was Sunday, and he would happily go back to bed for a single day off that week. Now, if somebody with dementia is missing, every second counts. So you can register a person with a medical alert and an Alzheimer's Association safe return, and GPS monitoring might be helpful as well. Yeah, you heard me. Put an Apple AirTag on him or a tracker. All right, nutrition is a concern. This could be due to loss of interest in food, decreased ability to feed themselves, any comorbid conditions, long-term care without adequate assistance. When chewing and swallowing become difficult, use pureed foods, thickened diets, nutritional supplements. Remind the patients to chew and swallow, and offer them liquids frequently. Make sure you use a quiet and unhurried environment. And you might need to use adaptive equipment like easy grip utensils or finger food to help encourage them to self-feed. We do have alternatives to feeding by mouth. We have NG feedings, which should only be short term, and a PEG tube, which again comes with its own risk of aspiration and tube dislodgement. In order for family members to make this decision, they need to weigh the outcomes versus the potential risks of these invasive procedures. And as far as caregiver support, remember there's more than 16 million unpaid caregivers in the US. It disrupts all aspects of their care. And we might need support groups to help the patient, right? Those are pretty useful to our caregivers. One thing I want to mention here is that and I think I want to talk about it under the safety section just because we have obviously infection as well. So I would consider that to be, a risk and not just under safety, right? UTIs and pneumonias are very, very common. It's the cause of death in many Alzheimer's patients. So if somebody has a change in their behavior, fever, cough, dysuria, then we need to report that. In late stages, people with Alzheimer's are also at risk for skin breakdown due to incontinence, immobility, undernutrition. So we need to make sure we're working with that. We want to maximize nutrition and also work on their skin care. So as we go down here, let's ask a question. You can read it here and press pause, and then we'll go to the answer. Okay, so for this, the answer is D, having no memory of preparing a meal and forgetting to serve or eat it. This is because the type of memory loss that this person would have as a warning sign would go beyond forgetting an assignment, forgetting names, forgetting deadlines. It's difficulty performing familiar tasks. It's not abnormal for most people to become distracted and forget something, like you leave something on the stove too long. People with Alzheimer's disease may cook a meal but then forget not only to serve it or forget that they made it. And misplacing things. For many things, temporarily misplacing keys, purses, that's normal, even though it's frustrating. But persons with Alzheimer's disease may put them in inappropriate places, like put their utensils in clothing drawers, the remotes in the refrigerator, and they have no memory of how it got there. Okay, so now we're going to move along to delirium. Okay, so let's enter the delirium mindset here and see what's different. You can see the fast facts here. Basically, a person with delirium can present with a variety of manifestations. They can be from hypoactive to lethargic to hyperactive, agitated, and hallucinating. And I've seen it every single way. It usually develops over a 2 to 3 day period, but it can develop within hours. The symptoms represent a change from baseline and may fluctuate. They do not occur due to a change in level of arousal, and they cannot be explained by another pre-existing, evolving, or established neurocognitive disorder, right? So it's sudden impairment. The exact cause is unknown, though we do suspect that there are contributing factors. It's rarely caused by a single factor. Dementia is the leading risk factor for development of delirium. And then delirium is also a risk factor in subsequent development of dementia. So many factors can precipitate delirium. You might be able to use a mnemonic to help you identify some causes of delirium. But again, the main contributing factor is probably impairment of cerebral oxidative metabolisms, might be inflammatory cytokines. It's most likely caused by a single factor. So in hospitalized older adults, up to 60% may experience delirium. It's linked to things like stress, surgery, sleep deprivation. It's a surgical complication. May also be impacted by pain and depression. It's usually the result of the patient's underlying condition with a precipitating factor or combination of factors. Again, demographic characteristics, age 65 and older, more likely to be male. And early manifestations also often include the inability to concentrate, disorganized thinking, irritability, insomnia, loss of appetite, restlessness, and confusion. Later, they may manifest as agitation, misperception, misinterpretation, and hallucinations. There's something called ICU delirium that's very common, and I think because of all the stimulation that's in the ICU, right? People cannot rest at all. So how is it diagnosed, right? So diagnosis could be difficult, but we look at their medical history, psychologic history, physical exam, close attention to the meds. We might do some lab testing to rule out causes, including CBC, electrolytes, renal function. Might need an EKG, urinalysis, O2 sats, eventually potentially even a lumbar puncture or brain imaging. And we do use the confusion assessment method, a CAM score, in critical care areas to help find delirium early. So how do you manage it? It can be difficult to manage. Treatment is aimed at protecting the patient from harm. We can encourage the family members to stay with them, provide familiar objects. I encourage family members to bring in pictures from home and objects that are familiar and helpful to the patient. You need to provide them a private room or one near the nurse's station, consistent staffing, reduced environmental stimulation, create a calm and safe environment, provide reassurance, reorientation using clocks, calendars, and again, using verbal communication and touch. In the case where somebody has ICU delirium, the most effective treatment we can do is get them out of the ICU. Additionally, make sure if the person has adaptive equipment or sensory equipment, including glasses, hearing aids, use them and use them at every opportunity. Avoid restraints. All right, so here's our question. It's asking, why do we do CAM? Okay, so pause, read the answers, and now I'm going to show you the answer. All right, this is because delirium is a state of temporary but acute mental confusion. It's common, life-threatening, and possibly preventable. So clinically, delirium is rarely caused by a single factor. It's often the result of interaction with the patient's underlying condition and a precipitating event. So if you take anything away from this, is that we can absolutely potentially avoid delirium, and also it's reversible. Medications are reserved for those patients with severe agitation. And those would be folks that their delirium is interfering with their medical therapy, putting the patient at increased risk for falls and injury, and any non-pharmacologic interventions have failed. And there are the medications that we would use. All right. Next question. I'm going to move on. All right, so the answer to this is C. Mental changes are most likely caused by infection and are most often reversible. Remember, it's a state of temporary but acute mental confusion, common, life-threatening, preventable, possibly reversible. So my final thoughts are with you to, what not to do. This is from a doctor, but this infographic, but super important, right? Don't think delirium's benign. It can increase hospital stay and can lead to death. Don't keep waking them up at night. Don't stick tubes into patients that they don't need. Don't order tests you don't need that's aimed at the doctors. Don't laugh at or argue with patients who have delirium. So although a lot of this is aimed at doctors, we can look at it too. If a doctor orders a test that's not generally needed, you can ask about it. It's okay. I want you to ask, especially if the doctor orders an MRI on a brain for a patient who's unable to complete an MRI. You might want to question that. And I guess we'll leave it there. All right. Thank you so much. All right, you guys, this has been Dementia and Delirium. If you like the video, please click the like and subscribe button. Thank you so much for watching. Have a great day.